iGlaucoma presents Podium Presentations on Glaucoma Rewind for national presentations that were missed or those you watched but wish you could press rewind and watch again. In today's podium presentation, the talk was presented at the National Glaucoma Society Annual National Glaucoma Symposium East virtual meeting.
It's an honor to be here. I'm happy to be able to share some insights in glaucoma surgical and clinical treatment. And I am honored to have the opportunity to be invited to this lecture. So today we're going to talk about choices, and more choices. There's so many options now that are becoming available for glaucoma patients, which is great. And we're going to dive into it. These are my financial disclosures, more relevant or ones related to device companies for MIGS procedures. So today we're going to talk about some MIGS background. I know you're all familiar with MIGS, so I'll just kind of go into some background about that. And then we'll talk about knowing what's available. Because there's certain steps in just trying to figure out how to choose, and it starts with knowing what's available. And we'll focus on mechanisms of action and discussion of that. We'll also talk about evaluating these devices, which one works best, what's the efficacies, and we'll go over some studies there. We'll also talk about device selection for the patients, and so deciding which one works best, when it works best. We'll talk about putting these things into practice with a case selection with some surgical video. And then we'll also talk about some of the things that matter postoperatively, what could go wrong, how to take care of those things. And then we'll put all those things in practice, talk about how to take some action. So we all know that glaucoma treatment has, for a long time, the traditional glaucoma treatment has been trabeculectomy and tube shunts. Trabeculectomy has been considered the gold standard. And we know that it can work really well when it does work well, but it also can be wrought with different types of complications, and those complications can sometimes be very vision threatening. And so there's been a search about trying to find other options. And that search has, whenever there's problems, we look for solutions, and those solutions have led us to MIGS. And MIGS has been, over the last decade plus, has been exploding, as we all know. There's so many different procedures coming out, and even more coming down the pipeline. We started off with trabectome and then exploded into all these other procedures that we will be discussing today. But along with all of these options, which have been great for patients, has also led to some level of MIGS overwhelming confusion. Which one to use, when to use it, and which one should I begin starting to adopt in my armamentarium. So it's like being a kid in a candy store who's super hungry and you can only choose one thing and trying to figure out which is the best option. So how do we choose with all of these different types of options that we have? And as I mentioned earlier, it's best to start with knowing what's available. Just being able to understand is great by looking at what the different mechanisms of action are. So I like to always categorize the different MIGS procedures by mechanism. And there's goniotomy, there's bypass stenting, there's canaloplasty, there's using the subconjunctival space, which can, in some instances, is not so much considered a MIGS procedure, but more of a LIGS procedure, like less invasive glaucoma surgery. And then there's a combination of these techniques. I mentioned here in the graph suprachoroidal space, which has been a mechanism that was offered before with the CyPass, but is no longer available, but we hope will be in the future. So starting with the mechanisms of action of the trabecular meshwork removal or goniotomy, this is where we are removing tissue that is of the trabecular meshwork, typically the juxtacanalicular tissue, which is an area seen of high resistance for outflow. And the procedures that could do this are the trabectome, the Cahook dual blade, the GAT, or gonioscopy assisted transluminal trabeculotomy, or the Trabex or Trabex Plus. I don't mention Omni here, but we'll mention that later in the combination. So with the trabectome, what makes the trabectome unique is that it has a handpiece that's attached to electrical and fluidic system. And that system allows for there to be continuous irrigation aspiration. And why that's helpful is that it allows the chamber of the anterior chamber to be well formed and well pressurized, which makes the technique of removing tissue with the ability of having egress of heme once that trabecular meshwork tissue is removed. It helps it to be stabilized so that you have a nice clear view throughout your procedure. It also helps, the fluidics helps with removal of that tissue. And then the electrocautery system, or the electroablation system, allows for as we remove the tissue, the ablation of the edges so that there's a nice clean cut to help expose those collector channels that are within the outer wall of Schlemm's canal. The Cahoop dual blade came after, and this was a device that kind of gained on the idea of let's be able to remove that tissue, but without having a whole system and also an expense associated with it. But a single device that has dual blades that are sharp edged with a ramp that allows you to remove in a strip the trabecular meshwork tissue to expose that outer wall of Schlemm's canal and the collector channels. Then you have the GAD, or Gonioscopy Assisted Transfemoral Trabeculotomy, and this was a procedure that was coined by Ron Fellman, and this procedure allows you to use either a Prolene catheter, Prolene suture, or a catheter, and you make a small incision in the trabecular meshwork to create a little goniotomy. Through that, you can put the Prolene or the catheter into Schlemm's canal, and you can track it up for 360 degrees. What this does is then allows you, as you pull on that Prolene or catheter, to kind of excise the trabecular meshwork and roof it, so then you have exposure to those collector channels for up to 360 degrees. Then you have the Trabex and the Trabex Plus. This was initially called the Goniotome, and this device kind of played on the concepts of having a blade. So these are single-use devices. With the Trabex, it's just serrated blades, serrated dual blades that uses you can use it to cut a strip of the trabecular meshwork tissue away. When you add the Trabex Plus, what this is the ability for that handpiece to be attached to a phaco unit, and that allows for the irrigation and aspiration. So similarly to the Trabectome that has a fluidic system, this Trabex Plus has that fluidic system to allow for those perks of pressurizing the chamber that can help with the view and help reduce the bleeding during the procedure. But there's no electroablative assistance here. So it's a pure blade doing the excision with the fluidics. So the next mechanism of action is the bypass stents.
It's 11 o'clock.
And these bypass stents are used in order to create a stable conduit for allowing access of the aqueous into Schlemm's canal and then to the collector channels. And the devices that allow for this are the iStent first generation, the iStent Inject W, and then the Hydrus. So the iStent was the first device that was implanted in the eye, and this stent, to be honest, really opened up the concept of doing this in combined with cataract surgery and extending procedures to more comprehensive doctors as opposed to just glaucoma specialists. So with the iStent, it was a device made out of titanium, and it was inserted into the Schlemm's canal, and at the outlet had an open patent opening to the anterior chamber for the aqueous fluid to be able to flow. This was a device that can only be done in conjunction with cataract surgery, compared to the last category that could be done in conjunction with cataract surgery or with a standalone. The goniotomy procedures can be done standalone, but the stents have to be done in conjunction with cataract surgery. So the iStent being done with cataract surgery, it was for early disease and early stages of glaucoma. And what was found was the stents can work well when they're placed near a collector channel, but sometimes they might not be quite as efficacious. So if you use more than one stent and you have more access to more collector channels, you get more efficacy. And so eventually the iStent Inject came out. And now we have the iStent Inject W, which is an enhancement of the design, but the iStent Inject has two stents. And so if you try to place those two stents in your collector channels, you get more efficacy. And there was a little bit more ease in this design in terms of intuitive placement of the iStent in the trabecular meshwork tissue. Then you have the Hydrus microstent, and this is a stent that now has a similar outlet, so a patent conduit for fluid to flow through it, but its design is different in that it's larger and longer, and so it actually has multiple mechanisms of action. So you can insert the device into Schlemm's canal, and that actually, the insertion for up to 90 degrees allows you to kind of open up that area of Schlemm's canal. Actually, if there's any kind of adhesions there, you can lyse them, and it creates a stable patent opening in Schlemm's canal, in addition to that access to the bypass that allows access to the anterior chamber. With the next mechanism of action, you have the dilation of the Schlemm's canal. And this is with viscoelastic material. And there's actually a multiple mechanism of action within this mechanism, because not only are you using the viscoelastic to stretch open the Schlemm's canal, but you're also allowing the viscoelastic to flush the distal channels, or the distal outflow channels, those episcleral vessels, as well as flushing out the trabecular meshwork, because the trabecular meshwork is like a filter. And so you're also pushing that fluid both posterior and anterior to be able to get multiple areas of treatment. So the procedures that can do this are the ABIC with eye track, or aventranal canaloplasty. And with this device, what's unique about it is that there is a catheter. The eye track catheter has an illuminated tip that allows you to have good visualization. So after you are entering the eye and you make a small opening to create a goniotomy, little incision with the trabecular meshwork, you then take the tip of the catheter and you enter it into the Schlemm's canal, very similar to the concept of the GAT, as I mentioned before. So you enter it into the canal and it can go up to 360 degrees. Now with the catheter, you have a visco injector, and so you have your assistant turning the visco injector as you're pulling out the catheter, and that allows fluid to come out, that viscoelastic. And so that's what's exuding out in a pressurized fashion to help flush out and stretch out the distal collector channels, the Schlemm's canal, and the trabecular meshwork. Now, the dual mechanism of action is to do that dilation of the canal plus trabecular meshwork removal. And this can be done with the Omni surgical system as a one unit, but it also can be done with the eye track if you can combine using the ABIC plus the GAT technique. With the Omni surgical system, this is unique in that it's a single device. So you enter, you make the incision in the cornea, and then you enter the eye and you're ready to go with an instrument that has a tip that has a sharp tips to make the little goniotomy, and then inside is a Prolene suture. And you can use the device to wheel in that Prolene suture to create an opening in the Schlemm's canal, or you're putting the Prolene into the Schlemm's canal, and then when you dial it back, you're releasing viscoelastic. If you go back into the same trap, you can then pull the Prolene suture and then create the goniotomy. And you can do that in a number of ways. You can either do it for 180 degrees, or you can do it for up to 360 degrees if you turn the device around and do it on the other half of the eye. So it allows for a lot of variability in treatment for the patient. The next mechanism is the shunting of the subconjunctival space. And like I mentioned, this mechanism is considered a less invasive glaucoma procedure because as you're using a device, which is the Zengel stent, as you're placing it from the anterior chamber into Schlemm and into the subconjunctival space, you are also utilizing mitomycin C as you create a bleb and using the mitomycin C to help the bleb stay open. So that use of mitomycin C and that creation of a bleb does make it a step up in terms of the potential future complications or future treatments of that bleb, so it makes it a little bit more invasive, but less invasive than a traditional glaucoma surgery like a trabeculectomy. So you have that Zengel stent, which is made of porcine gelatin that's about 6 millimeters in length. And this is a device that was that is a single unit. So you have a inserter that allows you to go through the anterior chamber and then right above the trabecular meshwork, insert the tip of the device, push forward, and then you enter into the subconjunctival space. Now, over the years of using the Zengel stent, there have been a number of different ways people have decided to use it. I still use the ab internal approach, but I use a slightly modified technique. I call it the Air Zen technique that I adopted from Ike Ahmed that allows me to pre-treat the conjunctiva with air and then with viscoelastic to balloon up and separate the subconjunctival space from Tenon's tissue so that I have a target for where to put my Zengel stent when I insert it from ab internal. But there are also other techniques that go ab externo, going from the outside in, and different variances. I have found very good success with my technique. I actually have a video of that on my eye glaucoma YouTube channel using my Air Zen technique. So with all these techniques, which one would you consider using? Well, in my opinion, the more the better. Why? Because you have different mechanisms of action, and glaucoma is not a one-size-fits-all disease. Because there are so many different nuances to our patients, as well as all these other factors, it's better to have more than one in your armamentarium because it allows you to tailor to each individual scenario. For example, you might have a patient who has a different stage of disease. Not all devices work with all different stages. Our stents work with mild to moderate, whereas if we have a patient who has advanced disease, you can consider using some of the other techniques like goniotomy or canaloplasty. You can also have sometimes you need a standalone procedure, not one that doesn't have to be combined with cataract surgery. Sometimes, depending on the angle anatomy, you might choose one versus another. Sometimes your insurance doesn't, the insurance is not covered for the patient for a particular procedure, and so you have to choose one that is, because not every patient's going to want to pay out of pocket for this technology. And then sometimes you might be at a hospital, and so the one hospital might allow for certain techniques, but not another. And so you might have to tailor what you do based on what's available at the hospital that that patient might be able to go to. So there's all these different factors, so that's why having more is better in my opinion. So which one works best? Let's evaluate the efficacy by looking at some of the clinical trials. So with the trabectome, there's a numerous number of different articles going over the clinical evidence for the trabectome. But one is the first decade of trabectome surgery, where they looked at nearly 5,000 trabectome cases up to 90 months follow-up. And this was a multiple number of surgeons in this database. And what they looked at in terms of the survivability or the success rate was a pressure that had to be at least 21 or below, at least 20% reduction of eye pressure from baseline, and no additional glaucoma surgery. And so what they found is that 66% of patients in trabectome alone had success at up to 90 months. 85% success was seen in patients who had trabectome plus cataract surgery after 60 months, or about 5 years. When looking at trabectome in a meta-analysis of trabectome outcomes, there was a evaluation of 64 papers, whittling down to 14 of the best papers. And what it was found was that the pressure lowering was about 36% from baseline, and the final pressure was around in the mid-teen range. And there was ability to decrease the number of medications by about almost 1. Now, looking at the Hook literature, there were some evaluations of the KDB looking at it as a standalone. They were looking at patients who had opening with glaucoma mild to moderate. Most of these patients were pseudophakic. And in these 53 eyes, what they found is when they divided the patients into high pressures and low pressures, that 88% of the patients who had the higher pressures had at least a 20% reduction from baseline. If you look at the graph, you can see that in the blue is the overall patients combined, but when you separate out, the high pressure group was the gray and the low pressure group was in the orange. And you can see that from day one, there was a significant drop in eye pressure, and that reduction of eye pressure was maintained over the period of the study. There was also a significant reduction in the number of medications. Over 2/3 of the patients reduced their medications by at least one or more. Again, looking at the KDB, but not just a standalone, but now in conjunction with cataract surgery and open-angle glaucoma patients, in these 52 eyes, there was also significant reduction of eye pressure. 100% of the higher IOP group, when it's subdivided into high pressures and low pressures, 100% of the higher IOP group had at least a 20% reduction in eye pressure. And again, if you look at the graph, the overall is the blue, the orange is the pressure group that had the higher pressure group, which was above 16, and then the red was the lower pressure group. And you can see again, with reduction of eye pressure significantly from day one and consistently over the year of the study. There was also a significant reduction in medication. 85% of the low eye pressure group had at least one or more reduction of medication, which is usually what you would expect in the lower pressure group, where these patients have combined with cataract surgery. Their goal is usually to try to get off medications. Now, so looking at some of the information for the GAT procedure, This is a study that looked at 24 months, 24 months out. And this is Devinder Grover and his group. And what they looked at in their study was that the device or the gap used in a number of different types of glaucoma. So opening glaucoma combined with cataract surgery, secondary open angle glaucoma.
Don't need to answer this question again. It's just the screen that's coming up while Dr. Okeke is looking to get to back to her slides. Bud, you might need to unmute. Allow people to unmute. We can't hear Dr. Okeke.
Yep.
Okay.
And then looking at the outcomes, what was interesting is, okay, so for all the different types of groups of patients, they had about 25 to 46 patients in each group, and they looked at 12 months and 24 months. And preoperatively, the pressures ranged between 22 to 30, and postoperatively, they all dropped to the mid-teen to lower teen range, and that was consistent also at the 24 months. There was also a significant reduction in the number of medications. So the number of medications preoperatively ranged from 2.5 to 3.5, and they reduced significantly both at 12 months and 24 months. So again, giving evidence that this procedure can work well in various types of glaucoma and secondary opening of glaucoma. Now looking at the Trebex Plus, this is more so looking at showing what the benefit of the device is compared to passive dual blade goniotomy. So Trebex Plus is seen as active dual blade goniotomy with a fluidic system, and then the passive being more like compared to the Trebectome dual blade. And so what you see in the study is that they looked at the baseline anterior chamber depth, and you can see in the top is active and the bottom is the passive. They both have similar depths of anterior chamber in the beginning. At the start of the intraoperative process, you have a depth of chamber that's even extended more, because with the active, you have the fluidic system starting to expand the anterior chamber, and at the beginning of the passive, you have viscoelastic in the anterior chamber to expand. But during the procedure, while you're doing the procedure, there's egress of fluid with the viscoelastic, and you see that the chamber shallows quite significantly. Whereas at the end of the active, you still have a fluid system going on, and there the chamber is very well formed. So just again highlighting the differences and acknowledging that the Trebex Plus with the fluidic system does help with stabilization of that anterior chamber, which can be very beneficial for the actual surgical procedure. With the iStent, there's been some evidence looking at how effective it is, and in the right population, one can get a very good outcomes, as seen by Tobias Nguyen and his patient population that had several different types of opening of glaucoma, as well as secondaries like pseudoexfoliative glaucoma. In his 5-year data, he had found that there was a significant reduction in pressure that maintained over a 5-year period. You can see in the graph a significant dropping of pressure that was maintained, as well as reduction in medications from 2 to 0.5 medications. The iStent inject was also reviewed in long-term studies. A doctor in Germany, Hengerer, looked at patients long-term, both combined with cataract surgery. There in Germany, they could do standalone. But what they did find was a significant reduction in eye pressure at 3 years for both standalone and combined groups, in addition to lowering of drops. Then with the iStent inject clinical trials that helped us to get approved here, they had also been able to see a significant reduction by 31% of pressure with the iStent inject plus phaco. The Hydrus, we'll give to the Hydrus that they have probably the most robust number of multi-centered clinical trials, and they have been given a kind of a gold stamp of approval in terms of their efficacy based on all of these trials that they have put out. There was the Hydrus study, and this randomized study looked at patients who had Hydrus plus phaco versus phaco alone. And at 12 months on washout, 88% of patients had reached the success goal of at least 20% reduction or more versus phaco at 74%. When you looked at 2 years, you can see that the Hydrus group is still doing well in terms of its efficacy, where there's a drop-off of the Cataract group. Then with another pivotal study or another randomized control study, the Horizon trial, you see it's very nearly identical to the Hydrus trial, and you see results that are also very similar. A Hydrus group had 86% success in terms of 12 months, at least a 20% reduction in the washout period, and that was similar in terms of its efficacy at 24 months, and then you see the drop-off in the phaco group in the gray bar. Also, looking at the Horizon study, they were able to show how well patients did in terms of having efficacy of eye pressure reduction with no medication. So you see the blue line represents the Hydrus patients that were at success target or better and had no medications, compared to the gray line, which is the phaco group. Here's some information looking at the eye tract and the ab internal canaloplasty. Here you have different authors who looked at eyes that were either standalone or combined with cataract surgery. A good number of patients with their baseline pressures being in the upper teens to low 20s. And you see at 12 months there was a significant reduction of eye pressure to the low teens, and also a significant reduction in medications as well. Looking at the Omni, there's there's a Romeo study that was a study looking at 4 different cohorts of patients. So whether Omni done as a standalone or Omni done in combination with cataract surgery, and several publications looking at these outcomes. In one of the arms looking at the combination of cataract surgery, they divided their patients in patients that had high pressures above 18 or lower pressures 18 or below. And the cohort, the first cohort showed that their baseline eye pressure was 21.9, and you can see that there was a 31% reduction from baseline, and also a 45% reduction with the number of medications. In the cohort that had the lower eye pressures, their reduction in eye pressure wasn't as significant, but they did have a good significant reduction in the number of medications. In terms of the pseudophakic group with Omni as a standalone, again, they subdivided their patients into patients who had elevated pressures and lower pressures, and their baseline pressure for the cohort 1 was 21.8, and there was also a significant reduction in eye pressure medication of about 28%, and also a medication reduction of 29%. In the cohort that had the lower eye pressures, they had a 10% reduction in their eye pressure, but a 35% reduction in their number of medications. And so thinking about, we talked about the different options, doing something as combined versus standalone, this be good evidence of thinking about the Omni as a good standalone device in patients who are looking for more pressure relief, who may be on maximum medical therapy or have already done SLT, and you're trying to avoid the options of the traditional glaucoma surgeries. Now, in looking at some evidence with Zen, this is a study that had looked at least 2 years of results from Zen, and what they were looking at were patients that had open-angle glaucoma that was uncontrolled, and their population of patients had baseline eye pressure from 18 to 33 on 1 to 4 medications. And in terms of their endpoints, they were looking for how much pressure reduction from baseline is at least 20% or more. without having to have any additional surgery, and with fewer medications that they started on. And what they found was that their success rate was about 67% at 12 months and about 66% at 2 years in terms of being able to reduce the pressure by 20% or more. And the complication profile was similar to that of trabeculectomy or tube shunts. So looking at the data, when asked which one works best, well, in my opinion, they all can work well, but it also depends on which patient you choose. So in the right patient, it can work well. So let's switch gears to talking about, well, when does it work best? And thinking about device selection. Well, I think that in terms of MIGS procedures, it's always good to set the stage well with setting right expectations, both for you as a surgeon and for the patient. You always want to over-deliver. You don't want to over-promise. So when you're looking at success, you're looking for at least around 20% reduction, maybe 20 to 30% reduction, and typically one medication reduction. Now, if your eye pressures are super high, what you're trying to do is get to target. You may not get as much medication reduction, so you don't want to overpromise that. When your pressures are well controlled, you're looking for medication reduction, so that's what's more typical. So setting up the stage for expectations is important. Sometimes you get more than that, which is great, but it's always good to try to set the stage correctly. So an ideal patient for MIGS is open-angle glaucoma, good nerve reserve, meaning patients who have cup-disc ratios of about 0.75 or better, early to moderate stage. The visual fields and OCT correlating with that. Also on 1 to 3 medications, and the goal, like I said, to 20 to 30% reduction or into the mid-teen range, and or maybe reducing your number of medications. You should know who is good, but you also know who isn't good. So a poor MIGS candidate is someone who has, let's say, it's a severe open-angle glaucoma, maximum medical therapy, and progressing really fast. These are people who you want to try to avoid the MIGS and go straight to something that's more traditional, because you really need to make sure you get the pressure down. I've told patients that sometimes, you can go to these procedures, and let's say maybe you're still on 1 or 2 medications. At that point, maybe you consider doing a MIGS after, because that's still possible after traditional glaucoma surgery to get additional pressure going with the reduction of medicine. But in those situations, you want to not look at that as the best MIGS candidate. And then also when there's a lot of synechial angle closure, especially if it's a uveitic patient who has a lot of synechiae, high synechiae, and chronic conditions that are not well controlled, that's set up for the potential for this to happen again. Neovascular patients are not good MIGS candidates for that angle. The congenital anomalies, because their angle anatomy is not normal. And then if the patient has corneal opacity, if you cannot see the angle, I can't see through the cornea, you're not going to be able to see the angle structure as well to be able to do the procedure well. In terms of the clinical exam, there are certain things that you want to look for. You want to acknowledge the number of medicines that they're on, acknowledge the preoperative eye pressure, determine the stage of their glaucoma by the slit lamp exam, looking at the cup-disc ratio, also the diagnostic testing. You want to look at the slit lamp to see if there's any secondary characteristics like tear exfoliation or pigment dispersion. All these things help in terms of deciding which procedure you might want to do. And then when you think about MIGS by the different categories, so as I approach the patient, I have all these things that I'm thinking about in terms of which MIGS procedure will work best for the patient. And so as I'm examining the patient, I want to know what kind of stage they're in, because if it's early to moderate, pretty much be any of the MIGS procedures. But if it's more moderate progressing to advanced, then you have to say, okay, the stenting are for really mild to moderate. Okay, if you're getting to the advanced stage, you shouldn't be doing those procedures not really covered in terms of their indication. And so then you're looking more at the goniotomy type procedures, or the combination of goniotomy and Gonioscopy, and then also the Zen, or the stenting procedure, subconjunctival stenting. Then when you look at the angle, if your angle is narrow, there's also some limitations here, because there are some procedures that are indicated for only open angle glaucoma. So you have a little bit more versatility with the goniotomy procedures to be able to do cases of narrow. And also, in my opinion, there are some benefits of having certain devices like the trabectome or the Cahook dual blade. They have the flat tip of their the flat edge of their the handpiece tip can act like a great tool to remove and lyse gonioscopy that are in the angle, and do it in a way that's very smooth and not traumatic to the iris tissue. So then after you have areas that you open up the angle and remove those synechii, you can then go in with your device and then remove the trabecular meshwork with exposed Schlemm's canal. And that can really work really well in chronic narrow angle glaucoma patients. And then there's also the option of just bypassing the angle and using the subconjunctival stent. Then I mentioned with when the angle's open, just about any procedure can be available to be used. And then in terms of phakic status, we kind of mentioned this earlier, there are certain procedures that you can do as standalone. And those include those that the goniotomies that remove the TM, the viscocanaloplasty, the combination of the goniotomy, viscocanaloplasty, and the subconjunctival stenting. These can be done in patients with a phakic, but they're not ready to have their cataracts out yet, so you just do it as a standalone procedure, or in patients who are pseudophakic. In terms of the procedures combined with combined with cataract surgery, it could be any of the different procedures that I mentioned. Another tool to use in the evaluation is gonioscopy. It's so important to be able to understand what's happening in the angle to help you decide which procedure to use. As I'm looking at the angle, I'm deciding if this is a patient who needs something to just, is their angle wide open? Is there a little bit narrowing there? Is there a little synechii there? How much pigmentation is there? All these things. Is there angle recession there? These things will help decide. Some other patient selection considerations are what their medical history is, surgical history, have they had previous glaucoma surgery, like for example, if we're thinking about the Zen, what the conjunctival look like, is that something that's feasible? Have they had multiple SLT, ALT before? Is it effective? Has it had any impact on the way that the angle looks? Have they had any, do they have uveitis? Is it chronic? Is it well controlled? Are they a steroid responder? Is it fake? Are they fake or not? And then also, are they on blood thinners? I found that I do try to remove or lessen blood thinners in patients before surgery. If they're on baby aspirin, Coumadin, Plavix, any of these things, if they can be stopped prior to, if it's safe for the patient to be stopped prior to, it's better because you do expect some level of bleeding during the procedure. Now, sometimes I might choose one procedure over another if the patient can't stop. So I tend to see that there's less bleeding in patients who have stents or canaloplasty compared to a goniotomy. So here's some just a compilation of some pearls in terms of bypass stents and canaloplasty. These work well with phakic patients that have a visually significant cataract, both of these. But canaloplasty can only be done standalone. These work well, these two groups, in mild to moderate open angle glaucoma controlled on 1 to 3 medications. They also work well, like I mentioned, with patients who are easy bruisers or who are on anticoagulants that can't come off. In terms of the goniotomy or the combination goniotomy and canaloplasty, these can be from early, moderate to severe glaucoma. These can be done standalone or combined with phaco. These will work well, as I mentioned, with narrow angle, especially the ones with the handpiece, the trabectome, and the hook. These work well in the pseudoexfoliation, removal of that TM and pseudoexfoliation is a very good mechanism of action for that particular kind of disease. And then when the patients are severe but they're controlled on 1 to 3 medications, this can also work well. So let's put it into practice by talking about an actual case and looking at some surgical video. So here's a 66-year-old male, a Caucasian male, who was referred to me by an optometrist for evaluation of glaucoma and cataracts. So he's currently off medications because he had had an effective SLT, but that SLT effectiveness only lasted for so long because his last visit, his pressure was 25 and 26. Prior to his treatment of the SLT, his pressure was 24 in both eyes, and right now he's complaining of glare and inability to drive at night. His ocular history is significant for nuclear sclerosis, non-compliance with medications, with his eye medications, and a history of the SLT in 2018 that was effective for about 8 months. He has diabetes, hypertension, is on medicine for that, and has no allergies. On his ocular exam, his best corrected vision is 20/25 and 20/20. His VAT shows significant glare at 2150 and 2200, and his slit-line exam shows significant cortical and mucosclerotic cataracts in both eyes. Tonometry by applanation shows pressures of 22 and 23, and his central corneal thickness is pretty good at 540 and 557. Gonioscopy is wide open on both eyes, and his cuspis ratio shows 0.7, and you can see how his nerves show fairly cupped concentric cupping, no particular notching, and maybe an overall slight depression in his retinal nerve fiber layer. So here on OCT, we see that he has some significant retinal nerve fiber layer loss in the superior temporal, and inferior temporal areas in both eyes. On visual field, we see that he has some early superior and inferior arcuates in both eyes, slight decreased reliability in that left eye. And so we diagnosed him with mild to moderate glaucoma in both eyes with visually significant cataracts. And his visual field is retinal nerve fiber layer. His pressures all correlated with active disease that needed to be better controlled. And that short-term SLT made us not feel like we needed to repeat that. And his history of noncompliance made us feel we needed to be more proactive. So we decided to do a cataract surgery, use the standard lens, and also combine it with the Omni surgical system with a target set at upper teens for him. So here's some video going over the Omni surgical approach. It's really important to have, ideally, a patient that has a wide open angle. In my opinion, I like to have angles that have a nice delineation of the scleral spur and the trabecular meshwork for ability to have very easy insertion of the Omni. Here I am, I always check the tip to make sure that it's coming out appropriately, but there's a little viscoelastic also coming out at the tip. And I decide that I'm trying to figure out where I want to treat. I want to make sure that I treat both inferiorly and superiorly, so I'm going to start inferiorly. And here I place the gonio prism on, and I use the tip of the Omni to score the trabecular meshwork to create just a really small goniotomy. And the tip is ideal to just either you can do a little reflection or you can wiggle, and it can just make that slight opening for you along where the TM is. And this allows you to enter, make an opening to Schlemm's canal. So here I'm angling the tip about 20 degrees, and then I'm inserting my Omni ProLane suture. And you can see I'm looking to see that it's behind the trabecular meshwork, and easily, and I'm going slowly to make sure that I'm not feeling any signs of resistance, the patient's not grimacing in any way, because there's the visualization is limited for the whole area. So I've gone and I slowly come back, and I can see that I'm still on the right track. There's that hue of blood in Schlemm's canal that gives me a good confidence that I'm in the right space. And so I've initially I released the viscoelastic, come back, and now I'm going back to do the goniotomy. And here I pull, and you see that white hue of the Schlemm back wall of Schlemm's canal, making me feel that I've removed the tissue well. And now I'm going to go into the other direction, and I'm inserting the catheter into that Schlemm's canal, and again pulling back. And I don't go all the way out; I just stay so that I can easily enter again, and then do the goniotomy on the other side. And it's nice with the Omni that there's versatility. You can either do 180 degrees or with the visco. I often do 180 with the visco and then 180 with the goniotomy for mild disease. Maybe more moderate, I might do 360 of the viscoelastic and then do 180 of the goniotomy. And then if it's severe disease, I might do 360 for both. So in terms of the postoperative management, I tend to try to minimize the use of steroids or either lower dose steroids, or if I use prednisolone, I use something that is a faster taper so that sometimes there could be, in my experience, some postoperative pressure spikes if you use too much steroids early on. I then will also use an NSAID, and I use this over the course of steroids and an NSAID over the course of 5 weeks, along with an antibiotic that I use for a week. And then I usually stop any kind of prostaglandin analog. If a patient is on, let's say, prostaglandin analog and a combination medicine, I will take off the prostaglandin analog but still keep them on their other medications the same because of that concern about the pressure spike through your postoperative period. And then you need to watch also for looking at the gonioscopy after to make sure there's no development of an synuclei. And in terms of this patient, they did well. But remember, the post-op pre-op visit was 22 and 23. Postoperatively, they really maintained pressures in the 16 to 17 range at 1 week, 1 month, and then at 1 and 2 years out, they were still maintaining off of any medications pressures that were at our target. And then also looking at the studies for this patient, he maintained his level of retinal nerve fiber layer damage for 2018, 2019, 2020. There was no change, possibly slight improvement in his findings, but definitely no change that was seen in both eyes. And then also his visual fields maintained stability throughout that time period, showing that he had an excellent result with that particular choice of cataract surgeon. So we also have to think about, well, when things go well, it's great, but we also have to be prepared when things don't go as well. So another thing that we need to think about is if there's hyphema. There are ways intraoperatively to try to prevent hyphema from happening, making the eye pressure really high at the very end of the case. I also use pilocarpine at the end of the case intraoperatively. But if hyphemas appear postoperatively, it's really important to try to help to minimize them. I have found that using pilocarpine is very helpful, especially when you have a goniotomy procedure, and also helpful to try to prevent any synuclei formation as the person is healing. So usually these will clear fairly quickly, but they can happen. We actually do expect some level of bleeding in the eye at the time of surgery. So it's important to try to treat it with using the steroids as well as pilocarpine. In regards to elevated eye pressure, this is something where that can happen. We talked about the possibility of steroid response. Maybe there's development of PAS formation in the angle. That's why you need to be looking for it. Maybe that's a stent. The stent tip got occluded, but maybe PAS. And so that's also something to be considering. So you might need to burp the wound initially. I sometimes will burp the wound even up to a week out, even up to 2 weeks out, to try to relieve the pressure needed. And then if you need to change the steroids or drop them down in frequency or change them to a lesser potent, less potency steroid, or use NSAIDs more and steroids less to help with the healing process. Then in terms of if there's PAS formation, like I mentioned before, I use pilocarpine. If I see any sign of it, pilocarpine helps to prevent more from happening. So anywhere I use 1% pilocarpine, it's usually very well tolerated, and it is something that can be used anywhere from twice a day to 3 times a day. Then sometimes there's prolonged inflammation, and sometimes it's been set up for potential steroid response, but one has to treat it. Sometimes, again, I use steroids, but I might use more NSAIDs to help with the inflammation. In some settings, one might have to use more potent steroids like use of Durezol, or even sometimes we use oral Medrol dose packs for some patients. But again, trying to avoid, I don't typically use analog injections because I want to avoid long-term pressure spikes, but sometimes these help with prolonged inflammation. And sometimes there's need for additional surgery. I've mentioned before that you can do MIGS procedures after traditional glaucoma surgeries. You can also do MIGS after MIGS procedures. Like, for example, if someone had a stent that was maybe efficacious but not enough. You can go back and do maybe a canaloplasty or goniotomy procedure. And then sometimes patients might need a traditional glaucoma surgery, or maybe a stenting procedure, subconjunctival stenting. Rarely do I remove the implants, but if there's a situation where there's been either the pressure has increased from where it was before surgery, as opposed to this not being effective at all, my thought is that maybe the stent might be occluding a certain collector channel that's important to be more patent open. So I might take out the stent or implant in that situation. And then rarely you might have to wash out the anterior chamber because of long-standing edema. So where do we go from here in terms of taking action? Well, I think that it's important for you to learn about all the different MIGS procedures. And today we've done that because we've gone over all the ones that are available. And when you see patients, you should start looking and asking yourself questions. Are these glaucoma patients stable? Do they have a visually significant cataract and glaucoma, whether controlled or not controlled? Are they compliant? Are they progressing? Have they already had SLT? Sometimes patients have had SLT and they're on massive meds and, thinking about traditional glaucoma surgeries, it might be a good standalone MIGS procedure case. So it's important to just start thinking about looking for patients. Using your gonioscopy, sometimes that will help prompt you to think about different potentials for these MIGS patients. And then refer them to your surgeons that do MIGS procedures. I would tell your patients that there's options, because it's great to be able to tell a patient that you're on all these drops. In the future, when you have cataract surgery, there's a way to get on to have use of less. And then there's also the possibility of being able to have better control of your glaucoma. And then also be very general when you're talking about MIGS, because MIGS, as I mentioned before, can be various types of procedures that one surgeon might do, or different settings with insurance or a hospital. So it's better to kind of send them from MIGS in general as opposed to a specific type of MIGS procedure. You don't want to have the patient all excited about a certain procedure and told that they can't have it, and then backtracking to try to explain why this procedure would be the one that you choose for them. So if you want even more guidance, if you like that kind of information, there's even more in a book that I wrote called The Building Blocks of Trabecular Surgery Patient Selection. This book was initially started when I was doing trabectome, but in the process of writing the book before it was finished, I started adopting so many different other techniques, and I realized that there's so many similarities in these MIGS procedures, so the book became more of a MIGS general in terms of its terminology and its approach. I've had a lot of different doctors who've utilized the book, like one of my colleagues, Dr. Steve Sarkisian, who mentioned that this book is not only for surgeons using trabectome, but in all MIGS. And one of my good friends, Walt Whitley, who had looked at this book, has a copy of it of his own, and knows that it was really beneficial for him in understanding MIGS, and found it to be very beneficial for both optometrists as well as ophthalmologists. Right now, we have there's a special discount for the book. I'm using the code MIGS21, and it's available at the KuglerPublications.com if you're interested.
Want more videos like this? Check out the iGlaucoma YouTube channel library. Check out the upcoming Season 2 of MIGS Success Surgical Secrets, where a video of common challenges and solutions will be featured. Subscribe to the channel so you won't miss it. Hey, want a must-need glaucoma tool that you can download right now? Grab my 2022 Glaucoma Medication Guide in the description box below. You'll get all the most commonly used glaucoma medications right at your fingertips to help you quickly make decisions about which glaucoma drop is right for your patient. Download it now. Thanks for watching the iGlaucoma YouTube channel, a place for glaucoma innovation made easy for eye care professionals.